Hello, my name is Richard Vincent. For a long time I've been associated with Prime, and for a long time I've been a cardiologist in a teaching hospital involved in medical education as well. And we're going to talk about a topic called What Does the Patient Think? Actually, you could read that in several ways. What does the patient think? Or what does the patient think? But at any rate, I want to focus on the consultation where we're engaged with the patient, and it's up to us to notice, to think about, what does the patient think? As doctors, what messages do we give and how are they received? What is that conversation about? So, what does the patient think? We're going to look at under three headings. What does he think about his illness? What does he think about his treatment? And what does he think about what we say? So what does the patient think about his illness? What we do know is that what the patient thinks has a powerful effect. It affects his mood, his coping, his adherence to treatment, and ultimately his recovery. There have been a lot of data gathered about the cognitive thinking of patients, how they look at an illness when they first develop symptoms. And these are described in terms of identity, consequences, timeline, control and cure, cause, and coherence. Looking at the identity first, when a patient first develops symptoms, there's a reaction which says, what is this? What am I feeling? And why is it there? And of course there are a lot of symptoms that patients can feel. Their first question is, what does this mean? The second thing that patients seem to think about is what therefore is going to happen. What are the consequences of the illness I now think I have as a result of these symptoms? Is it serious? Does it have really bad consequences? Maybe it'll have little effect. Maybe it'll affect my finances or my status. Maybe it'll affect the way I see myself as a person, my value. Another feature that's thought about in the cognitive response to new symptoms is how long this will last. What sort of timeline will this illness exhibit? Maybe my illness will last only a short time. Maybe my illness will last for a long time. Maybe this illness is likely to be permanent. Or maybe my illness is likely to recur in a cyclical sort of way. Now, an important element also thought about is the degree to which the patient themselves can control or cure the illness, or others can control or cure the illness. They may feel that my illness will improve in time, that there's a lot I can do to control the symptoms or progression of the illness, that there's very little I can do that can make it better. My treatment will be effective in curing my illness. Maybe that's a possibility. Maybe recovery from my illness depends just on chance or fate. What I can do to determine whether my illness gets better or worse is going to be effective and important, or maybe make no difference at all. It's almost always a question in people's minds as to what caused the illness. Is it germs? A virus, maybe. How did I catch it? Maybe it's due to diet, pollution. It's inherited. It's by chance. Commonly it's stress. Sometimes, admittedly, it's my own behaviour. Sometimes other people are responsible. Sometimes it's poor medical care. Maybe it's due to my state of mind, or something about my immune system. So in thinking about illness, we've had identity, consequences, timeline, control and cure, and cause. These seem to be, from our research, the way that people think about a new symptom and its implications for the presence of an illness that they're about to develop. On top of all that, there is something called coherence, the way all this hangs together and takes shape in their mind. Now that, if you like, is a cognitive response, thoughtful, logical. But there is also an emotional response. Inevitably, there is an emotional response to illness or the possibility of illness. And that seems to be separate from the illness severity. The severity of illness doesn't necessarily determine a severe emotional response. It's also separate from underlying emotional traits. So that you may be a very emotional person, but gaining an illness doesn't automatically mean you'll respond in a very emotional way. What does seem to affect the emotional response is the illness beliefs, what your cognitive decision about that illness leads you to think about its identity, cause, etc. So emotional and cognitive responses are important, of course, in what patients think about their illness. Generally, the emotional response is triggered by a cognitive response where the consequences of the illness are likely to be severe, where the illness is likely to be cyclical, that is, it'll repeat even if it goes away, and of course where there's little possibility for control either by the patient or by the helpers. So if we take an example, this is irritable bowel syndrome. If somebody with that condition has positively identified that as the likely illness, if they believe it to have adverse consequences, that the timeline will be prolonged, that there'll be a poor chance of control or cure, and that maybe it has a psychological cause, then these will affect not only the thinking, but also the experience of the illness. So a patient with that collection of, if you like, cognitive and emotional responses will have less vitality, they'll be less satisfied with their health, they'll have a lower quality of life, and they're likely to demonstrate more anxiety or depression. So those are some things about what the patient thinks about his illness. What about his treatment? What do patients think about their treatment? In the NHS in the UK, we spend about £11 billion, 13 billion euros, on drug costs every year. That's a lot of money. Particularly as it's well documented that about 50% of those medicines prescribed for chronic diseases aren't taken. The usual phenomenon of the prescription is cashed out, if you will, the tablets are taken home, but actually the medicines are either not taken at all or taken less often or in lesser dose than is prescribed. Now, the 2 points of thought that seem to arise out of this are a fairly straightforward balance between patients considering the necessity of their treatment and their concerns about the possible adverse effects. And it's the balance between those two that seems to determine the readiness with which they will start or continue to take their medicines. So adherence to preventative therapy, and here's an example from asthma, is worse when the consequence of the illness is adverse, when the control or cure is seen to be poor, in other words, not much influence of the treatment is likely. So therefore the treatment necessity is doubted and the treatment concerns are high. And that's a very powerful collection of ideas, which means the patient is likely to put the medicine down the sink or the toilet rather than take it themselves. And the same will go for other forms of treatment, not just medication, not just inhalers, but exercise, diet, other lifestyle changes. Now, if we consider the patient as a whole person, where these logical and emotional responses are present, where it's not just a question of treating them as though they're biology, then it's helpful to think about the fact that others are observing our lack of doing just this regarding patients as people who have an intelligent interest and emotional response to their illness and their treatment, and who have important thoughts in their mental life and in their spiritual life about what is occurring to them. In 2008, the King's Fund, an independent body within the UK that analyses what the health service is doing, published a report called Seeing the Person in the Patient, to draw our attention to the fact that there is unease in the health system about how patients are treated, not in the sense of which medical intervention is offered and how effective that is, but how they're cared for, how they're looked after. In other words, treating them as a person, talking about patients at the end of their bed without any understanding that the patient in the bed will be anxious, will be concerned that very important data about themselves are being discussed outside their hearing. So thinking about that last of our three headings, what does the patient think about what we say? Think about what we say. What we say in front of a patient is extraordinarily powerful. 5 minutes in a hospital of ward round time is the one very short period in a patient's day that they hear something of what we say, apart from what they might overhear. So I've collected some various phrases and sentences I've heard spoken by doctors around hospitals, and I'd like you to think about, what does the patient think of what they've just heard? Here's the first. I can't find anything wrong with you. We've done lots of tests, but they've all come back negative. What does the patient think? Well, I think the patient thinks, well, you've just done the wrong tests then, haven't you? Of course I got something wrong with me. It hurts. I don't feel well. That's not normal. So either you're telling lies, hiding something from me, or you're incompetent. It's not a great start. Here's another one. I'm sure your palpitations are nothing to worry about, but I'll just refer you to the hospital for a checkup. The waiting list's about 3 months. What does the patient think? Well, I think what many patients will think is, so you're not really sure that my palpitations are nothing to worry about, because you want me to go to hospital, so you don't really know. I've got to wait 3 months, and you're telling me I might just have heart disease, so what's going to happen in 3 months while I'm waiting? Am I going to drop dead? It's all right for you. Now here's a nice one. I'm pleased to say it's only a small stroke. Okay, you are pleased. I'm glad you're pleased. I really don't want a small stroke. I actually don't want a stroke at all. That sounds to be like actually really rather bad news. I don't feel particularly comforted by that. And actually, I don't think you understand how it feels to have a stroke, no matter how small. Well, here's another one. You can leave hospital now. I must say your GP was quite wrong when he thought you were having a heart attack. It's just some joint pain in your chest. What does the patient think about that? Well, he might be very pleased that it's not a heart attack and that it is just pain in the ribs. But what is he going to think about his GP? Here's the hospital specialist on some sort of pedestal and a high salary who's saying the GP was quite wrong. Was he? Can I trust him to get it right the next time? And how about this? We think it best for you to have an artificial valve put in. It's a common operation. What do you think about that? How about, well, it might be a common operation, but actually it sounds pretty big to me, having a new heart valve put in. Do you really understand what it feels like? What am I going to go through? Here are some tablets. You might find them useful, but do look on the leaflet in the box. Now this comes about quite reasonably because in the tablet box, in the box of pills, there are warning lists of things that these tablets can do to you. The problem is they become completely formidable. There are undesirable effects, serious side effects, and serious cardiovascular effects of this medication. And they range anything from slight flushing and headache to dropping dead suddenly, with stroke, heart attack, seizures, and a few other unwelcome things on the way. Now, genuinely, what do you do if, as a patient, you read this? Your doctor says, we'd like you to take these tablets. Oh, and by the way, you could possibly drop dead or have a stroke or something. But anyway, keep going. A close relative of mine was in that situation, offered high blood pressure pills to reduce her blood pressure to avoid her getting a stroke or other complications. And one of the first things in the drug insertion packet said, this could cause a stroke. So she didn't take them, and later on did have a little stroke. Do we really understand what we're saying to patients and how they hear what we're saying? These tablets will reduce the risk of your getting another heart attack. You will need to take them for the rest of your life. Well, that's good, sensible medical advice. But asking patients to take tablets for the rest of their life is rather like saying, this illness is never going to go away. They may be preventative, they may be helpful to reduce the chance of recurrence, but nevertheless you're now taking tablets, and you're taking them forever. So presumably the risk of your getting ill again is present every day between now and when you die. So explaining that to patients is important, so that they understand and can get a sense of the importance of taking those tablets, the sense that it isn't a definition of your still being ill, but just correcting those things that might underlie a problem in the future. So, what a patient thinks about their illness is critical to how they interpret what's wrong, and therefore how they react, and indeed how they progress through that illness and recover from it. What they think about their treatment will certainly affect whether they take it or not, and indeed the power of its effect when they do. And what they think about what we say happens all the time, whenever we as health professionals say something to them. And it does behove us to try very hard to put ourselves in their position, to imagine what it's like if we can. If we've been a patient, we may know from first hand, but actually to think through what it sounds like to hear what we're saying to them as patients, how that's going to affect them for their thinking now and in the future. And then just one final note, and that is, as a Christian, I find it quite amazing that the Lord Jesus put himself in my position to experience exactly what it was like to be a person, to be human, and to experience all the things that we face, from wellness, through loneliness, through suffering, to death and beyond.